Hi, I'm Mohamad Mohty. I'm a professor of hematology at Sorbonne University and Saint-Antoine Hospital in Paris in France. We are here at the IMS, the International Myeloma Society annual meeting in the beautiful city of Toronto. The weather is fantastic for the months of September, and the Congress has been a great one as usual. The myeloma field is moving so rapidly, and there are many exciting news. Of course, you're asking me about the highlights of this Congress, and that will take us for another 5 or 6 hours. So I'll try to be brief and gives you what my personal feeling about the highlights. For instance, when it comes to the young and fit patient newly diagnosed multiple myeloma, I think there's no more debate today. It's about using quadruplet induction with an anti-CD38 monoclonal antibody plus VRD, bortezomib, lenalidomide, dexamethasone. The debate is about transplant versus no transplant, and we have more and more emerging data showing that those patients who are after induction are able to achieve deep MRD negativity, measurable residual disease, usually 10-5, 10-6, as the threshold is even better. Actually, you may skip transplant. Although I must confess that in most European countries, we do continue to offer high-dose chemotherapy and auto-transplant with high-dose melphalan, because we believe that these results are probably the best results that we have achieved so far. Another controversial issue is about the maintenance therapy after transplant, for instance. And there is a debate about doublet versus single agent. And namely, this is about using daratumumab lenalidomide combination, whereas historically we have used lenalidomide as single agent. Again, it's a hot debate. My personal feeling and what I can glean from this Congress is that probably most patients should receive doublet maintenance with daratumumab lenalidomide. Now, the big question is whether we should give this continuously or for a fixed duration. And this is where I believe the measurement of MRD, the evaluation of MRD, is going to give us a clue. And in principle, those patients who are able to achieve deep MRD negativity, sustained deep MRD negativity, and sustainability is about maybe 9 months or 12 months between two measurements, probably they will be able to stop or to switch at least to a single agent. That was the young and fit population. Now we have the older myeloma population, and actually, again, the debate here is, should we use standard of care anti-CD38 lenalidomide dexamethasone, for instance, daratumumab lendex, isatuximab lendex, or should we give them quadruplets with daratumumab VRD or isatuximab VRD as in the Cepheus or IMROS trial? We've heard in many communications debating about how to choose between the triplet versus quadruplet, but at the end of the day, it is about actually the fitness of the patient and the comorbidities. In general, despite being old, a fit patient may be able to receive a quadruplet, and this is where we can achieve the longest progression-free survival. On the other hand, frail, much older patients are going to be treated decently and very nicely with an excellent outcome with Dara Lendex. For the future, the next question is about whether I can incorporate a bispecific antibody, namely, for instance, an anti-BCMA plus an anti-CD38 and lenalidomide in the frontline setting, with the idea of hitting harder, getting a deeper MRD negativity, and hopefully, at least from my perspective, to be able to deliver a fixed duration treatment. And I believe this is crucial from a patient quality of life, from a patient preference perspective. I've never met a patient who explained to me that he or she loves to receive treatment forever. So this is really important. And this idea, the concept of combining anti-CD38 monoclonal antibody plus a bispecific, is now being tested in a randomized phase 3 trial, and I believe in 2-3 years we'll get these results.